listening to the Pharmacy Podcast Network.
Pharmacy benefit managers, better known as PBMs, are responsible for negotiating payment rates for a large share of prescription drugs distributed in the United States. Recently, state Medicaid systems, policymakers, and national pharmacy associations have expressed concern that certain PBMs' business practices may not be consistent with public policy goals to improve the value of pharmaceutical spending. This podcast series is all about PBM reform. Listen to the discussions, share these podcasts, and help build a new pharmacy payer system which supports our independent community pharmacies, encourages fair and transparent competition in the marketplace, and most importantly, is designed to deliver the best patient care.
The PBM Reform Podcast series returns. We have been out there listening to some of the experts that we follow within PBM Reform, what's happening within the court systems, as well as pharmacists changing the game. Pharmacists who are building payer models that never existed 2 or 5 years ago, cash-based pharmacists who are now building clubs in order to completely remove the PBM from the healthcare system entirety. And it really shouldn't have to be that way. That Dom Meth from Pittsburgh, Pennsylvania, rest his soul, him and his sons have been deep into specialty pharmacy and pharmacy. But Dom Meth Sr., he helped to invent one of the very first PBMs back in the 80s. And the management of the steelworkers, medications, and their needs and their families' needs, it meant so much to the healthcare systems, the physicians, the pharmacists that were prescribing. It made sense. Formulary management, better pricing with manufacturers and generic balance. It made sense. And then all of a sudden, I don't know when it happened, but algorithms and very smart lawyers and people that were getting very, very greedy entered the space of our pharmacy benefit managers and took us hostage, took the entire profession of pharmacy hostage. PBMs have implications and domino effects on pharmacy care, ranging from burnout from pharmacists, burnout from our technicians, not staffing the pharmacies correctly because they can't afford in the model that it is, almost as if a big chain pharmacy out there eating itself alive based on its grip on the pharmacy marketplace and what PBMs are currently doing in the status quo of where we're at today. So we get excited when we can welcome experts in the field of PBM reform, bringing their knowledge and experience to try to help change and return to the goodness of what PBMs used to do for us. I want to introduce to the PBM Reform Podcast and the Pharmacy Podcast Network, Lindsay Bealor Greenleaf. She's Vice President in Policy at ADVI Health, ADVI Health. Lindsay, I am thrilled to welcome you to the PBM Reform Podcast.
Thanks for having me, Todd. Excited to be here.
So in intro and really setting the stage, you have had some really interesting experience in the realm of PBM. You've been referenced in so many publications since I've been digging and stalking you on on Google and trying to find more content. And I went back as far as 2016, 2017, which was kind of the bubbling, the water just started to boil a little bit. Now it's going crazy about how run amok the PBMs have become. And you know very well, our United States Senator Chuck Grassley and Maria Cantwell, they introduced 2 bills that seek to hold pharmacy benefit managers accountable for their practices and the rebate game and the price gouging and the pullback of DIR fees from our community pharmacists out there. Set the stage for us. What role do you play in this evolution of pharmacy care? And tell us a little bit about your work with ADVI.
Sure. So certainly not a new issue, as you've described. We've been tracking this troubling evolution for many years now. But at ADVI, we work with a number of healthcare stakeholders, pharma, biotech manufacturers, physician practices. We have some oncology practices that have in-office dispensing that They have some real concerns around PBM practices that we're going to talk about today. Also work with medical device manufacturers, diagnostics, digital health, all things federal, state policy related, you name it, we're working on it. So with the PBM reforms you're talking about, yes, let's talk about those bills that were just introduced. Before jumping into that, might be helpful to acknowledge the massive law that was enacted last year, the Inflation Reduction Act, and the significant drug pricing reforms that were part of that. And to acknowledge that the PBMs were totally spared in that new law. So, in August of last year, the IRA passed, and it included numerous drug pricing policies, most notably government negotiation. And we put quotes on negotiation. It's really government price setting for drugs. There's a policy for inflationary penalties if a drug's price increases faster than inflation, which, typically when that happens, it's because PBMs are demanding higher rebates and manufacturers don't really have much else they can do to mitigate that, but that's okay. We have those in place now. There's also Medicare Part D benefit redesign. Helpful $2,000 out-of-pocket cap is now in place for seniors taking Part D drugs. But, as part of all of this, there's one big giveaway to the PBMs, which is the law further delays or essentially repeals the OIG rebate rule, which we won't bore your listeners too much going into too many details. But you'll recall the OIG rebate rule was the rule from the Trump administration that would have stopped troubling rebate practices that are happening in Part D. By delaying that, for complicated reasons, the Congressional Budget Office has projected that that'll save the government $122 billion in the IRA. That was one of the biggest pay-fors. So all that to say, the Inflation Reduction Act included no reforms to the PBM's business model. Their business model is alive and well. They still have 80%, of lives within 3 PBMs. All of that's the same. And a regulation that the PBMs don't like, it's now further delayed. It cannot go into effect before 2032, which is another way of saying it's gone. So with that backdrop, they got quite a free pass and a massive sweeping law last year. So now it's 2023. If you want to complain about drug prices, you want to do something on prescription drugs, there's one stakeholder that has not been touched, and that's the PBMs, and that's where the scrutiny is going to be this year.
So part of the issue, Lindsay, that you're helping to bring to light is the fact that our consumers, which are being pinched, and some of them can't even afford their medications, or they're splitting tablets. They're not able to afford insulin. They're not able to afford technology like the continuous glucose monitors and so forth. It affects every aspect of medication treatment. Is the PBMs are so complex in their business models and how their business models change depending if it's 340B, if it's specialty medications, if it's your average Joe antibiotic over the counter, if it's special accounts that are set up, the rebates. It's so complex that the average consumer has no idea what's going on. And when they go to the pharmacy counter in a retail setting, and sure enough, the cashier or the technician is checking them out, and they say, that'll be $52. And they're like, wait, this time last year, it was a $10 copay. Why is it $52? Now they get angry at that tech or that pharmacy that's literally the entity that's in front of them, the healthcare provider that's in front of them. They're under the impression, wow, you pharmacies are so, gosh darn, grabby. And then the next layer, that's the first layer consumer of understanding. Second layer consumer is, no, it's not the pharmacies. Don't blame them. It's the manufacturer, that pharmaceutical manufacturer, is just ripping us a new one based on our tax about. And then it's finally the third person that has taken time to read and research and saying, no, it's actually the PBMs and the models that they've created and the once again, the effect, ripple effect, domino effect, whatever you want to say, that it's had on every aspect of medication management. not even giving our pharmacists, which is another podcast, the ability to do what they were designed to do and trained to do as PharmDs in order to do medication management and treatment modality change based on what's happening in the therapy, especially in our chronic patients. And that is all hostage. That is all hostage to the mighty, mighty PBMs that are taking massive amounts of profits and money away from the healthcare ecosystem and treatment system, which when we start talking tax dollar, that's what bothers me the most, is because there have been Medicaid systems set up and Medicare systems set up to service some of our most fragile of patients. So I loved in the article that you were quoted in where you said these fees benefit PBMs and the expense of the patients and pharmacies. Patients have faced high cost sharing based on undiscounted prices, while pharmacies are hit with huge, unpredictable, retroactive fees that penalize them for failing to meet measures that are often irrelevant to them. And then you go on to talk about oncology practices that dispense medications are frequently hit with fees because the PBMs say they haven't met certain measures, the standards and the scoring systems, and are completely incapable to cancer care, like management of diabetes and cholesterol. This infuriates me, Lindsay.
They're benefiting from the confusion and they're benefiting from the complexity of what it is that they do and the confusion just around their role in this whole setup here. It would take policymakers in the form of Congress, CMS, or the FTC, somebody to do something, and they're most inclined to do something when taxpayers are yelling about it. You have that consumer voice loud and clear saying we're angry about this certain thing. But when the process is this confusing, the blame is often placed in the wrong places, like you talked about. Point the finger at the pharmacist, point your finger at the manufacturer. It's just so complex that it's really hard to get these points across quickly and articulately in a way that everybody's paying attention. The other thing is, the PBMs know how to adapt. So once you get your messaging across on, let's say, manufacturer rebates, the fact that a drug's list price might be high, but if there's a lot of rebates paid back to the PBM, the net cost is low. The fact, the distortions we talked about, that cost sharing is based off of that high list price, even though the manufacturer's taking home less than 50% of that list price. That whole dynamic, progress has been made. From an advocacy perspective, patient outreach perspective, progress has been made. But then PBMs change the game. Now it's new fees. They're not called rebates, but they look a lot like rebates. Yeah. So they just make it more complicated. And just when you're able to articulate what it is that they're doing, they've moved on to the next thing. So that's been an ongoing challenge and something we're working on.
And then steering. So we have patients who have known their pharmacies in their communities for years. It's been multi-generational care. And maybe it's a family that has diabetes. And sure enough, it showed up in the next gen. And now they receive a letter from a pharmacy that says you have to now use a mail order pharmacy. You no longer have that relationship. The mailman or mail person drops off your medications once every 90 days. Who knows what the temperature is of those medications? Who knows what the follow-up is? There's now no engagement with a pharmacist to be able to sit with the patient once every 30 days, once every 90 days, and make a reassessment of treatment. Because guess what, people? This is really makes me angry. Your condition can change. And if you don't have a pharmacist kind of helping you to follow along your treatment, you may be missing an opportunity to level up in your care, add something, subtract something, deprescribe, maybe use less medications. These PBMs don't give any reference to care. They give every reference to profiting and to how do we make more money based on the system. I never, ever see white papers from PCMA or any of the three big pharmacies that are about, hey, here's how we've improved, say the magic word, care for patients that are suffering with multiple myeloma or hyperlipidemia or some serious disease that's really impacting their everyday life and living better. It's not about the care. And that should be screaming obvious to our legislators and to our Congress and to people that are setting laws in place to stop these PBMs from, like you said, evolving with algorithms and with contracting, with making up new ways to keep that revenue rather than using it for care.
Absolutely. Dr. Deborah Patt from Texas Oncology spoke to this exact dynamic that you're referring to at a hearing last week. February 16th, there was the Senate Commerce hearing on PBM transparency and accountability. Dr. Patt was a witness, and she talked about this. She said, due to the power of the top PBMs, the majority of oral cancer drugs are steered by the PBMs to their corporate affiliated specialty mail order pharmacies. The PBMs tell you this is a cost-saving measure. In reality, it allows them to effectively control the practice of medicine. We urgently need transparency and accountability. It's true. I mean, they're just taking that care aspect right out of the equation. And if we pretend for a second that the only thing that matters is money, whether the patient is on the right drug, should stay on that drug, let's pretend for some gross second that doesn't matter. From a cost perspective, there's potential for wastage. Dr. Patt gave an example of a cancer drug called Verzenio. She said that when this steerage happens, there's often times where she would have taken someone off of the drug or changed the dosage. But when the PBM has already done the steerage, that's already in motion. The script has already been filled, and you've got a whole month of Verzenio that's been wasted, and that's roughly $10,000. So, from a care perspective and from an economic perspective, it just doesn't make sense. But when you have 3 PBMs controlling 80% of lives in this country, what are you going to do? You don't have the power to push back. And it's very frustrating.
It's very frustrating. And we see it. We see it, year after year, manipulation to the existing markets. Downright lies being told to Congress people about how they're saving money. I never see savings. I always hear talk about savings, especially when there's medical switching, when it's just based on a contract and has nothing to do with pharmacy care. And the physician and the pharmacist are standing there with their hands on their hips saying, how dare you change therapy that I know is going to work because I'm tracking it. I'm making sure that it's being followed up on. And then you run into the business bureaucracy that has, once again, nothing to do with care. It has to do with how much money can we make on the system in private insurance, as well as our taxpayers thrusting gobs and multi-billions, if not trillions of dollars into the system. And once again, it's being sucked out, and we're leaving the patients without the care that they need. And boy, I tell you, when I talk about CVS and some of the antics, I absolutely love the pharmacists that I've met at CVS. Some of the most passionate pharmacists that are in the business, and how they want to be more effective, and they are even hostage in their own dysfunctional family. That it seems like the tyrant parent of the family is this, greedy fat person that is not paying attention to, wow, if I just let my pharmacist execute on the modalities and plans and treatments, we could heal people. We could have people feeling better. We could get them more services based on the money that we're missing and or wasting, so that pharmacists can do telemedicine, digital therapeutics that are now coming up, pharmacogenomics, testing your DNA, Lindsay, to make sure that your DNA is absorbing the medication that you're intended to have, and paying for that test and saving money. There's a savings. Why not put a patient on a specific psychotropic, knowing that they're going to work that drug the way that it's supposed to be used and leveraged, instead of just throwing these blind darts at a dartboard, and then once again, medical switching happens within 3 months. So it's a nightmare. It's literally a nightmare.
The tests around whether a certain drug is appropriate for you, based on a certain drug that a physician intends for you to have, that's the part that gets me. They don't care what the physician wants you to have. It's all about what does the PBM think you should have? And it really frustrates the physician practices, the oncology groups that we work with, the amount of time that they spend on the phone and the number of employees that they have to hire where their only job is to sit on the phone with PBMs and fight it out and say, no, my patient really does need this certain drug. You can't have us have step therapy, have a step edit where they take this other drug before they get access to the drug that I'm telling you they need to have. And they're often telling us that the folks that they're fighting this out with at the PBMs, they're not always doctors. They're sometimes nurses. And if they are doctors, they're not from the same specialty. So, at best, they're talking to another physician that's not an oncologist. It's really egregious. And I don't think patients realize how much work goes into getting them access to the appropriate drug. It's just so much time and energy from the providers.
So bring us up to date, and I'm excited about how the FTC seems to be joining the fight. But I need someone at your level to kind of clarify what position that they've taken, as well as the data that can continue to be given to them. And I'm also talking about if other PBMs are listening to this podcast right now, that are the fiduciary PBMs, the transparent PBMs who are also on our team fighting for reform, to give the data, to give as much data as possible to the FTC so that they can continue to dig into meaningful trade within the space of pharmacy benefits. But can you give us an update on how the FTC is being positioned?
Yes. So there is an FTC Section 6B study that's underway. It's called a 6B report that we're waiting to come out. That's in reference to a part of the statute, but basically it's a part of the statute that gives the FTC authority to ask companies like the large PBMs for this data. And so here is the quick history for you. In February of 2022, the FTC had a vote about whether they were going to engage in a study like this. The vote failed. There was debate around whether it was too broad in scope. Then they came back a couple months later, June of 2022, and the FTC, voted in favor of proceeding with a study on PBM's monopoly power. So the specific topics that they're looking into are the role of fees and clawbacks that are charged to unaffiliated pharmacies, methods to steer patients towards their PBM-owned pharmacies, the potentially unfair audits of independent pharmacies, the complicated and opaque methods of pharmacy reimbursement, prevalence of prior authorization, the use of specialty drug lists, and then lastly, the impact of rebates and fees from manufacturers on formulary design and out-of-pocket costs. What I just rattled off, that's a really solid list of things to look into. I'm sure the list could even be a bit longer. We'll take what we can get. They have sent out a request with questions on those topics that I just listed out to the top 6 PBMs, CVS, Caremark, Express Scripts, Optum. Obviously, they're the top 3 we talk about having 80% market share. They also sent this request out to Humana, Prime Therapeutics, and Med Impact Healthcare Systems. Those are the PBMs that they have, that they're requesting this information from. So at this point, we're waiting on the outcome of this report. We don't have a solid timeline on when the FTC will come out with this report. They gave those PBMs 90 days to get back to them with that information. That information is not public at this point. So at this point, we would assume those PBMs have submitted the information that was requested. The FTC is analyzing it, and they would come up with, release their report somewhat soon. At ADVI, we researched, some average timelines around how long it takes the FTC to, from start to finish, complete a Section 6B report. Somewhere around 18 months is the timeline for some past reports, but we don't have any confirmation on that. So we'll see. There's some hope here.
The U.S. Oncology Network and the National Comprehensive Cancer Network, both really influential in the space of cancer care. They understand that clinical decisions regarding that specific treatment, changes to treatment, medication usage, and the ongoing course and changes that happen in cancer care is being impeded and being blocked by some of these PBM practices. There was an article that came out in the AJMC just recently, not even a week ago, which references this by Dr. Leilan Wifong, MD.
Yeah.
And it's based on evidence-based oncology practice. So they're basically saying PBMs shouldn't even be in this discussion. We are clinicians. We are moving cancer care forward. And here's what we've discovered. Let's execute. Let's move forward with the treatment. And they're hitting a brick wall with prior authorization, assuring that it's the PBM's way. It's not the cancer specialist way. It's not the pharmacists in, taking data in response to medication, a 7-day, a 30-day, how are you feeling 90 days into treatment, responding back and tracking back to the physician and the specialist saying, hey, let's make an adjustment to the, this JAK inhibitor or change this medication. No. It's all driven by the hostage taking, as I keep saying, from the PBMs. And it blew my mind when I read this article from the AJMC.
There's also some reports from COA, the Community Oncology Alliance, that I recommend everyone take a look at. They're called, the reports are called PBM Horror Stories. And it's a compilation of various oncologists that are members writing into COA with patient-specific examples of what they've had to go through to get their patient access to the drug that they prescribed. It is, like the title implies, horrifying. There are months that go by, and these people are not complaining about something minor or mild. This is cancer. Every minute counts. And they give examples of how, the patient's condition has declines in their outlook for, favorable prognosis. It goes down. Like, these are real consequences. And it's often the PBM is just slow walking you. It's kind of like you have to prove how bad you want this drug. And it's running out the clock, really. Are you going to give up and just do what we told you to do in the first place? Or you're going to keep fighting? Okay, eventually we'll let you have what you said you needed all along. But it might take 3 months before you get there. It's really, really terrible. And they have some horrible examples in those reports.
Lindsay, what is your call out to our listeners right now listening? We have policymakers listening. We have pharmacy owners. We have association leadership. The APHA is involved. The NCPA, the National Community Pharmacists Association, is involved. We have a organization that's part of our network called PUT, Pharmacists United for Truth and Transparency, that's done a tremendous amount of work. But what's your call out to organizations listening in right now as to how they can literally help you, help them, help patients, and designing better pharmacy care and PBM reform?
I think the patient perspective, the patient-driven examples, as I mentioned in the COA horror story reports, those are incredibly effective. Not to minimize the voice coming from everybody else in this, supply chain here, the manufacturers, the pharmacists, the providers, obviously really valid concerns that everyone's raising. But when it comes to policymakers, they listen harder when it comes to a patient perspective. So I think we just have to keep amplifying those voices and those stories and keep aggregating them in an organized fashion to just make it clear just how this all really does impact patient care that should be driven by providers like doctors and pharmacists, not folks sitting behind a desk based in another state, not specialized in a certain area. We got to get it back to the way you'd think medical care should work. So yeah, amplifying the patient voice is a big one.
Well, that's good advice. And I know that there are community pharmacy owners listening in right now that have patients that call them that know them, that have known their whole family for years. They're part of the community that cry on the shoulders of their pharmacists saying, what can I do to change this? So you're absolutely right. We've always encouraged community pharmacists, independent community pharmacists to have a legislators' day where they invite pharmacists to their operation. They show them how they care for patients. They show them their computer systems and management, and obviously sign a non-disclosure and get these politicians involved in really understanding the grassroots issues of how this is impacting community health and public health, and how the PBMs are literally a public health threat. They are one of the biggest public health threats right now with the status quo. Not PBMs in general. When I opened up the show, I told you and told our listeners that there was a need and a meaning for good, well-run PBMs that are patient-focused, allowing our physicians and our pharmacists and our specialists to do what they do best, heal people, stabilize people, get their chronic conditions under control and move forward. But that's not where we are today. Today, it is all about the profit, and it's all about the PBMs, stockholders, raising that stock price. And it's just it's a travesty, and it's something that we're passionate about supporting. You are a fighter. You're backed by your organization that believes in this as well. I got to have you back. We got to have like an update from you every once in a while on the PBM Reform podcast. But I just want to thank you so much for this time.
Yes, thank you for having me. Would be delighted to come back.
How can listeners reach out to you? Talk to me about best place to link. I linked up with you on LinkedIn, so I know that you're out there, but what's another way to get a hold of you?
Yes, LinkedIn, or you can email me directly at lindsay.greenleaf@advi.com, or check out our ADVI website.
ADVI Health. We are excited that you're part of this fight, Lindsay. Thank you so much for being our guest today.
Thanks, Todd.
PBM reform is not a textbook process. This component of healthcare insurance will take time to figure out and will consist of many different players of the pharmaceutical supply chain. If you'd like to contribute information, data, or your own insights on PBM reform, please contact the Pharmacy Podcast Network. Send your email to publisher@pharmacypodcast.com or call us at 412-585-4001.